After the lamps are lowered, the room keeps its quiet shape. The work of medicine is often remembered through discoveries, but it was also made from listening, waiting, measuring, carrying, cleaning, and recording. Tonight, the history stays close to those ordinary details. In earlier centuries, the bedside was not a polished stage. It was a bed, a basin, a cup of water, a folded cloth, a jar, a bowl, and a page that slowly filled with remarks about breathing, appetite, sleep, pain, color, and waste. The physician stood close enough to hear the patient speak and far enough away to watch the face. A servant might carry away a basin while another fetched water, and a family member might stand in the doorway with one more detail remembered from the night. Medicine learned its habits in such ordinary rooms, among linen, paper, and the noise of a household trying to remain orderly while illness unsettled everything. Long before the modern clinic had standardized forms laid out on a desk, the sick room already demanded discipline. It asked for attention to small changes, patience with long hours, and enough humility to return again in the morning and compare what had changed overnight. Long before hospitals became crowded institutions, Greek medicine gave the Western tradition one of its most durable habits: looking carefully before naming. The old poems already show a world attentive to wounds and anatomy. Homer's Iliad described 141 wounds and used 150 anatomic terms, a reminder that the body had already become a subject for precise speech. By the time of Hippocrates, medicine had become an art, a science, and a profession. The surviving cases associated with his school show a remarkable discipline: careful histories, inspection, palpation, direct listening, and attention to sputum and urine. Disease was treated as natural rather than divine, and that change in thought mattered as much as any tool. A natural illness could be studied, compared, and expected to follow a course. The Greeks still lacked accurate anatomy and pathology, and they explained disease through the humors. But the habit of observation was already in place. The surviving collection contains 42 clinical cases, the sort of detailed record not seen again for many centuries. In those early rooms, the patient's own body and the patient's own account were becoming part of medicine's language. The asking of questions became a craft in its own right. Around the beginning of the 2nd century, Rufus of Ephesus wrote a book devoted entirely to questioning the patient. It is one of the first formal works on history-taking. His advice is strikingly practical. He recommended starting with the patient whenever possible, and turning to relatives and friends when speech or memory failed. He wanted the physician to learn whether the patient was troubled or clear-minded, strong or weak, and to understand where in the body the disease seemed to sit. He urged questions about when the illness began, how fast it had advanced, whether it had happened before, what the patient had been eating, how the patient slept, what the patient dreamed, what remedies and regimens had already been tried, and even where the water came from. He also wrote about nourishment, habits, the season when illness began, and the character of the pain itself. The same author wrote on the pulse and on diseases of the kidneys and bladder. Such details made the room wider than the bed. They brought the household, the routine, the weather, and the memory of earlier days into the case. The physician was not only listening to a cough or a complaint, he was listening for a life pattern that might explain why illness had arrived there and then. The center of medicine shifted over time, and each shift changed what the physician heard. In the old Greek world, the individual sickbed mattered most. In the Middle Ages, libraries and shelves of books carried much of the weight that direct observation had once held. By the 17th century, the bedside returned to the center, especially in the teaching of Boerhaave at Leiden, where students learned from the patient before any theory could get in the way. By the 19th century, the hospital had become the great stage of medicine, packed with cases and records. That long movement from bedside to book and back again ran alongside the authority of Galen, whose writings filled many volumes and remained the final word for generations. He studied anatomy through animals and added speculation where direct human study was missing. His work gave medicine a framework, but it also cast a long shadow. For centuries, a young physician could be surrounded by paper and still be far from the body itself. The room with the bed needed another kind of authority, one that could compare the page with what was actually seen, heard, and felt. In Alexandria, the body became something that could be opened, measured, and described with unusual precision. Herophilus studied the nervous system and the digestive tract, named structures in the brain, and counted the pulse with a water clock, analyzing rate and rhythm by using time itself as part of the examination. Erasistratus described the valves of the heart and the tendons that connected muscle to motion. He saw the heart as a pump, even if he misunderstood the direction of circulation. These were not casual observations. They were attempts to make the invisible legible while the body was still alive. The pulse, once only a beat under the fingers, was becoming a counted event. The body was no longer only a subject for philosophical argument. It was a place where number, timing, and structure could meet. Yet even in that Alexandrian world, human dissection remained limited and uneven. The knowledge reached through these openings did not settle everything. Galen's later authority gathered much of it into a grand system, but the habit of measuring, timing, and comparing had already begun to loosen medicine from pure speculation. For a long period after antiquity, human dissection faded and then returned in medieval Italy. In Bologna, the study of the body came back into university life, and the legal world helped to push it there. The Emperor Frederick II authorized public dissections on the bodies of executed criminals for teaching. Legal scholars wanted to know the causes of death, and that interest helped to open bodies that had once been treated as untouchable. Mondino of Bologna wrote the first book devoted entirely to anatomy in the early 14th century. It was not a grand illustrated atlas, but a practical manual, a handbook for students, moving from the abdomen to the chest and neck, and ending with the skull. Public dissections spread to Padua, Montpellier, Venice, and Florence, and in Padua, an anatomical theater rose in the 15th century. The classroom had changed shape. Instead of relying only on inherited text, a teacher could point to a body on a table and say, "Here is the organ, here is the vessel, here is the part that the page has named but never fully shown." The lesson was still incomplete, but the body itself had re-entered medicine as an authority. Vesalius gave that authority new force. In 1543, he published his great anatomy book based on personal dissection of human bodies, not on inherited animal anatomy. He performed the dissections himself, breaking with the habit of leaving such work to a subordinate. The result was a more accurate map of the body, one that physicians could trust when they later tried to understand disease in the living person. The illustrated pages did more than decorate a text. They made anatomy visible as a disciplined art, not merely a chain of old assertions. That mattered at the bedside because the physician needed a reliable picture of what lay beneath the skin and muscle before any useful comparison could be made with symptoms and signs. Vesalius did not end uncertainty, but he moved medicine away from the easy safety of repetition. The body could now correct the book. The patient's complaints could be set against an anatomy that had been checked by the hand and eye, not by authority alone. This made the bed less lonely. It linked the living room of illness with the dissection room where the hidden structure could finally be seen. Alongside anatomy, autopsy became a habit of inquiry. In Bologna, a suspicious death could bring a body before the authorities, and the earliest known forensic autopsy was carried out there in the 14th century. In the centuries that followed, physicians and anatomists increasingly treated the dead body as a place of explanation. Bodies of executed criminals were dissected for teaching, and bodies of the sick were opened as well. Families sometimes asked for autopsies so that a death would not remain obscure. In Copenhagen, permissions could be sought from the authorities, and Bartholin described ways of gaining access with tact and caution. In other places, the body might be inspected through an existing surgical opening or during embalming. Theophil Bonatus gathered 3,000 cases into a great compilation that matched disease histories with findings from the body after death. Lancy of Rome wrote De Subitanis Mortibus in response to the sudden deaths that alarmed Rome in 1706, and he gave exact measurements of organs as if the body were a landscape that could be surveyed after a storm. These books were built from tables, notes, and careful comparison. They strengthened the habit of asking what had happened in life and what the body would reveal afterward. The page and the body were beginning to speak to one another. Morgagni brought that conversation into a lasting form. His great work, published when he was already an old man, arranged a vast number of pathological findings with minute histories, symptoms, treatments, and autopsy results. He had studied and written for decades, and his book was the fruit of 60 years of deliberate labor. What made it so important was not only the quantity of material, but the way it was organized. Each case belonged to a clinical story. Each disease had a course. Each body after death was linked back to the room in which the illness had unfolded. Morgagni reviewed earlier writers carefully and credited them when credit was due. But he also insisted on a new way of thinking. Disease was to be found in organs, and those organs had to be matched with what had been seen during life. That was the great step. A fever, a cough, a pain, a swelling, a wasted face, and a dead body could now be read together. The patient was no longer only a set of complaints. The patient was a sequence of observations that survived into paper and then into pathology. Morgagni gave medicine confidence that internal disease could be correlated with the clinical history, even if the living body still hid its deepest secrets. Boerhaave turned that confidence into daily teaching. In Leyden, he had 2 wards in an old hospital, one for men and one for women, with 6 beds in each. Students from all over Europe came to learn from him, and many left to become leading physicians in their own countries. He made bedside teaching an art form. Each day he went round with his students, reviewing the history, inspecting the patient, examining the urine, and then attending the autopsy if the patient died. The patient was not examined much beyond that, because percussion and auscultation had not yet been discovered. What mattered was the routine. See the patient, listen to the account, look at the urine, then compare life with death. On those 12 beds, a generation of European medicine learned the discipline of repeated observation. The room became a classroom, the ward became a ledger, and the autopsy room became the final page of the case. Boerhaave's method did not rely on dramatic insight. It relied on return visits, careful attention, and the conviction that one illness could teach another if the details were kept in order. The French school carried that habit farther and gave it a tighter form. Pierre Charles Louis became a model of exact observation in the wards and the post-mortem room. He studied disease by staying close to the patient and by taking immense numbers of notes. His method began with the previous state of health, age, occupation, residence, family background, manner of living. Then came the present illness, in chronological order, with the patient's own statements and the physician's examination placed side by side. A careful record was made during the illness, and if death followed, an autopsy completed the account. French manuals of the time taught the same sense of order. The report of a case was to be written soon after the visit, while memory was fresh, with the name, sex, age, occupation, and place of origin set down at once. The absence of a symptom mattered nearly as much as its presence, because the record had to withstand another reader. In such work, the page stopped being a loose recollection and became a document. This was old bedside medicine at its most disciplined. The physician did not merely remember, he measured what had been observed, and the order of the page tried to preserve the order of the illness itself. In a crowded hospital, that order became a form of trust. Then came percussion, and the chest began to answer back. Onbrugger, the son of an innkeeper in Grasse, is said to have learned from his father's wine casks that a hollow container sounds different from a full one. After study in Vienna under Van Swieten, he worked at the Spanish hospital and spent 7 years refining a method of tapping the chest. He published his 95-page book in 1761, but it was not immediately welcomed. The technique was simple and careful. Tap with the fingers, sometimes over a shirt, sometimes with a gloved hand, and listen for the character of the note. Normal sound, resonance, dullness, flatness, each suggested a different kind of space beneath the chest wall. What had once been a vague surface became a field of clues. Later, Corvisart brought the method into wider use in 1808. Onbrugger did not invent listening, but he gave the ear a new task. The body could now speak in tones as well as in words, and the physician, standing at the bedside, began to hear that some kinds of sickness could be found by sound alone. The ordinary room had gained another layer of meaning. By the time percussion entered practice, the older bedside world was already complete in its own way. It had the patient's voice, the relative's memory, the urine flask, the wash basin, the notebook, the hospital ward, the anatomy table, and the careful return to compare one day with the next. It had pulse counted against time, body opened after death, and the discipline of writing what had been seen before the details could fade. The physician learned to read illness through small acts repeated often enough to become reliable. A glance at the face, a hand on the wrist, a question about sleep, a note about water or food, a look at the page, then a look at the body after death. That was the long apprenticeship. Listening did not arrive all at once. It formed slowly. In rooms where lamps were lowered, linen was changed, and the work of care was carried out with patient hands. Before later instruments became symbols, medicine had already taught itself to pay attention to what the living body offered in silence, in speech, and in the record left behind. By the time the physician reached the ward, the room had already been arranged by others, a bed straightened, linen folded, a basin set near the wall, a stool drawn close, and a book waiting for names and remarks. The room was not built for spectacle, it was built for repetition. And repetition taught medicine how to compare one day with the next, one body with another, one sound with the last sound heard at the same bedside. In Leiden, Boerhaave made that habit into a public lesson. He had 2 wards in an old hospital, 6 beds for men and 6 for women. With students beside him, he moved from bed to bed, reviewing the history, inspecting the patient, checking the urine, and, if the patient died, following the body to the autopsy table. From 12 beds, a generation learned a method. The room was small, but its discipline was large. Before percussion and the stethoscope, the physician's range was narrow. History, inspection, the pulse, and the excretions made up most of the practical equipment. A face, a hand, a vessel of urine, a note about stool or sweat, a body line under a blanket. These were not minor details. They were the means by which illness could be approached before the chest had been tapped and before the ear had been brought to a tube. Long before the modern clinic, Rufus of Ephesus had already treated questioning as part of the room's furniture. He told the physician to ask the patient first, then relatives and friends if the patient could not speak clearly for himself. He wanted to know when the disease began, how quickly it moved, whether it had appeared before, how sleep had been shaped, what sort of dreams had come, what food had been eaten, what water had been drunk, what habits and regimens had marked the days, and what medicines had already been used. The room became intelligible through such ordinary things. A bedside was no longer only a place where symptoms appeared, it was also a place where a life could be laid out in order. That ordering became sharper in the French school. Louis Martinet wrote that disease had to be studied at the bedside, where it could be seen without the disguises that books sometimes impose. He asked the physician to be calm, kind, and attentive, to listen closely, to question gently, and to show real interest in the patient's welfare. His advice sounds simple, but the larger point is stricter. The visit was not complete until what was seen and heard had been translated into an exact account for others. Martinet wanted the case to read like a picture copied carefully from life. The leading symptoms had to be written down first, in the order in which they appeared when that could be known. If a usual symptom was absent, that absence mattered too, because silence on the page could make the observer look careless. The notes were to be transcribed immediately after the visit into a book kept for that purpose. The room did not end at the bedside rail. It continued into the page. He also wanted the first lines of a record to carry the practical facts that made a person distinct: name, sex, age, occupation, sometimes country or district of origin, and the diseases common there. Chronic illness and acute illness asked for different kinds of attention, but both demanded a disciplined history. The book became a second room, one that could be carried away and reopened later. A physician who wanted accuracy had to preserve the order of things while they were still fresh. That shift mattered because medicine had already lived in other rooms. Libraries had been the focus during the Middle Ages. The bedside had become central in the 17th century, when Boerhaave could teach from a dozen beds at once. The 19th century made the hospital the main setting. That change widened the field of observation, but it also made the physician answer to a larger crowd of patients, students, and records. The page itself had been gathering authority long before that. Banitas brought together 3,000 cases in his great repository of disease on the dead body, pairing histories and observations with what the body showed after death. Morgagni carried that impulse further. His work arranged cases with minute histories, symptoms present, treatment used, and then the autopsy findings, all carefully indexed and discussed. The page became a set of shelves on which disease could be laid out by type and compared across patients. Lancy in Rome showed the same desire for exactness in sudden death. He wrote from autopsies performed during a year when the city was alarmed by many unexpected deaths, and he measured organs rather than merely naming them. The precision mattered because it tied the visible body to the course that had led there. Every careful note made the next bedside less isolated. It became possible to say not only that a patient had died, but what sort of change had been present all along. By the early 19th century, that sort of discipline had a place large enough to keep many patients at once. Paris became the center of medical life from 1800 to 1850, and it was not only because its physicians were brilliant. The city itself had become a concentration point for hospitals, students, and illness. It stood amid other sciences as well, with mathematics, physics, chemistry, and biology, all moving through the same intellectual streets. Progress in those fields flowed into medicine. People moved into the capitals in great numbers during the Industrial Revolution, and many arrived with tuberculosis, typhoid fever, and other long, difficult ailments. For those without family or stable lodging, the hospital was often the only place to go. The overcrowded wards produced something the older bedside world had rarely offered: quantity. Physicians could see many cases, compare them, and choose the kinds they wanted to study. In Paris, there were dozens of hospitals, thousands of patients, and thousands of medical students. The Hôtel Dieu alone held about 1,000 beds. A room that had once sheltered one sick person now belonged to an institution. Even so, the old problem remained. The physician still needed a way to know what lay inside the chest while the patient was alive. Leopold Auenbrugger found one by using percussion during his years at the Spanish hospital in Vienna, where he worked among soldiers. He had studied medicine under van Swieten, who carried Boerhaave's hospital habits into Vienna, and he spent 7 years refining the method. The chest became a sounding surface. The hand became a tool of inquiry. Auenbrugger's own directions were plain and practical. He recommended a gloved hand of unpolished leather or a tight-fitting shirt over the chest, and he struck with the tips of the extended fingers held together. He listened for different notes and learned to distinguish the normal sound from tympanitic, dull, and flat notes. He also studied cadavers with fluid in the chest and varied the timing of the percussion with breathing. The room did not reveal everything at once, but it began to answer. His work did not spread quickly. The first reviews were hostile or dismissive, and the book rested almost unnoticed for years until Corvisart, working in Paris, encountered it and tested it on the wards. Corvisart used the palmar surfaces of his fingers instead of Auenbrugger's direct tapping. After years of experience, he published an unabridged translation and his own findings. Prestige helped the method travel. Once Corvisart had tied percussion to a respected clinical name, the ward had a new sound in it, and the sound acquired authority. The next refinement came from a smaller object. Pierre Piori invented the pleximeter, an ivory plate that sat between finger and skin. It softened the blow and sharpened the sound. At his demonstrations at the Pitié, he moved from bed to bed on a high stool, mapping organs on the skin with colored crayons until the patient's torso looked like a geographical chart. It is an arresting image, but its meaning is practical. The body was being translated into a surface that could be marked, compared, and reviewed by others in the room. Laennec carried this work into another register. The familiar story begins with children and pieces of wood in a courtyard, but the important point for the hospital is what he made from that memory. Direct listening was often awkward in the wards, and he found mediate auscultation more workable. He experimented with forms, turned the instruments himself on a lathe, and settled on a cylinder about 45 centimeters long and 4 centimeters wide, later made in 2 pieces for portability. Each purchaser of his book received one. The object did not merely amplify sound. It gave listening a shape that could be held in the hand. Laennec's routine at the Necker Hospital shows how tightly the object, the room, and the day were bound together. For 3 years, he worked intensely with the new instrument. In the wards, he demonstrated signs from late morning to noon, often speaking in Latin at the bedside. After that came a lecture in French or a post-mortem examination, where the findings of the body were compared with the signs heard during life. The ear was never left alone. It was tied to the table where anatomy answered back. The tube also solved a problem of distance and posture. Direct listening could be awkward in the crowded ward and difficult in some situations, especially where physical closeness was not practical. The stethoscope let the physician keep a measured distance while drawing the ear closer in a disciplined way. It turned a difficult encounter into a repeatable one. The object was small, but it changed how the body could be approached without turning the encounter into a display. His entire day was built from the same repeated motions. He rose early, gave consultations while dressing, went to the hospital, returned rarely for lunch, then resumed visits into the afternoon and again into the evening. This was not heroic in the theatrical sense, it was meticulous. The same corridors, the same staircases, the same beds, the same notebooks, the same stretch of attention carried from one patient to the next. Medical knowledge grew inside that schedule. Visitors who studied under him did not simply hear the theory. They watched him demonstrate the signs from bed to bed, then saw the autopsy table used to test what had been heard. One later visitor recorded how steadily he worked through the hospital day, teaching even when he was worn down by his duties. Notes and sketches moved together with the demonstrations so that the student left not with a rumor of method, but with a way to repeat it. Students came from far beyond Paris to watch and learn. They listened at the bedside, attended the lectures, and returned home with stethoscopes in their bags and new habits in their hands. An instrument that had once been a local experiment became a portable rule. The ward could now be recreated wherever a physician stood beside a bed and used the tube to separate one sound from another. The hospital room no longer held all the practice. The practice traveled home with the student. Yet the room still needed the page. Morgany had already shown how powerful it could be to arrange many cases with their histories, symptoms, treatment, and autopsy findings. Before him, Benitez had gathered thousands of cases into his great repository of the dead. These were not merely collections of curiosities, they were ways of holding together the voice at the bedside and the body after death. The record let one day speak to another, and one patient instruct the next. In the end, that is what the routine achieved. A physician came to a bed, asked about the illness, looked carefully, listened through the new instrument or tapped the chest, wrote immediately in a book, and returned later to compare the notes with the body or with the next day's condition. The room, the object, and the record worked together. Medicine learned to listen not only with the ear, but with the hand, the page, and the habit of returning. That discipline would shape the work that followed, carried by people who knew how much depended on a quiet visit, a careful note, and the exact sound a chest made when the hand met it just right. In Paris, that discipline found a larger stage. The 19th century turned the hospital into a machine for seeing. Peasants streamed into the cities, and wards filled with tuberculosis, typhoid, and every kind of fever. A physician could choose the cases he wanted, and the crowded rooms gave him more material than any private practice ever could. Corvisart made percussion respectable at the bedside. Laennec carried a wooden cylinder to the chest and turned listening into something more exact, more formal, more teachable. Students came from far away to watch, to copy, and to leave with the instrument in their hands. Pierre-Louis carried that habit even further. He lived in the hospital, took page after page of notes, and worked in the wards and the post-mortem room until the patient's story and the body's evidence belonged to one another. He asked first about age, occupation, residence, family, and way of life. Then he traced the illness itself, step by step, and kept the record as the case unfolded. If the patient died, he wanted the autopsy too, and when treatment was in question, he counted. He compared one group with another and showed that bloodletting for pneumonia was far less certain than custom had promised. Exactitude mattered more than habit. By the 1840s, though, even the French school had reached its limit. Observation and autopsy could describe disease beautifully, but they could not yet explain all of its causes. So the center of medicine began to drift toward Germany, toward laboratories, physiology, pathology, and the new experimental sciences. The setting changed again, but the discipline did not. Medicine kept moving from guesswork toward evidence, from impressions toward methods, from a bedside glance toward a chain of proof that could be followed and trusted. In the entresol room at La Charrette, the work did not stop when the ward rounds ended. The pages stayed open. A name, an age, an occupation, the first complaint, the change in breathing, the note from the post-mortem room, all of it had to be placed in order while memory was still fresh. That kind of labor rarely gets remembered, yet it is one of the ways medicine learned to carry itself forward. A case became more than a passing encounter only when someone stayed with it long enough to write it down, compare it, and return to it. That habit was already present in the older schools, though in a simpler form. At Leyden, Boerhaave turned two small wards in an old hospital into a place of instruction, one for men and one for women. Students came from across Europe to stand beside him on daily rounds. They reviewed the history, looked closely at the patient, and examined the urine. The setting was modest, but the influence was wide. A few beds trained a generation, and those students carried the habit of the bedside to other cities, other languages, and other institutions. From Leyden, the method traveled to Vienna through Gerhard von Swieten, who had learned from Boerhaave and brought his insistence on bedside teaching and autopsy into the old Vienna school. There, Leopold Auenbrugger worked at the Spanish hospital, mostly a military hospital by then. It was there, over 7 years, that he tested percussion again and again until the signs of chest disease could be sorted by sound. The hospital was not just a backdrop. It was the place where an innkeeper's son learned that a body could answer a question if the question was asked with enough patience. Corvisart took the method onto the wards and gave it public authority. He tested Auenbrugger's work, published his own findings with a translation, and through prestige and persistence, made percussion part of medical practice. This was more than endorsement. It was a signal to younger physicians that a useful idea had to survive the hospital before it could survive the profession. Around him, others tried to add something of their own. Clary invented the pleximeter, chasing a sharper response and hoping, as many ambitious clinicians did, to contribute something lasting to the craft. That urge to contribute is easy to miss if the history is told only through inventions. In fact, the discipline was built by people who tested, repeated, and refined what they had seen. Corvisart did not simply admire Auenbrugger, he carried the method from book to bedside. Clary did not stop at admiration either. He wanted a cleaner sound and a more reliable response from the body. The same pressure ran through the whole period. A diagnosis had to prove itself in practice, not just in theory. Laennec belonged to that same world, but his path was shaped by a family of medicine. After his mother's death, he went to live with an uncle who was a physician in Nantes, and he began studying medicine there as a teenager. Later, in Paris, he studied under Corvisart and worked with Bayle and Dupuytren in pathology and pathologic anatomy. He did not separate the clinic from the dissecting room. He wanted the signs seen in life to match the changes found afterward, and that desire drove him toward the stethoscope and toward a new way of listening. The years after that discovery were years of intense labor at the Necker Hospital. Laennec refined his technique, wrote his major work on mediate auscultation, and described sounds no one had named before. He also made the instrument itself, turning the first models on a lathe and shaping them into a portable form. Students came from far away to learn the method, and he gave each buyer of his book a stethoscope. The spread of the practice did not happen by abstraction. It happened because one teacher handed a way of hearing to another person, and that person carried it home. Those students found a man who worked beyond what his health should have allowed. One visitor described the rhythm of his days: ward demonstrations in the late morning, a lecture afterward, or a post-mortem examination to connect what had been heard in life with what the body showed later. The sequence mattered: bedside, lecture, post-mortem, listening, naming, confirming. Laennec's gift was not only that he heard differently, but that he kept the same case moving across these places without letting it disappear between them. Paris itself made that possible. From 1800 to 1850, the city became the center of medical life. Corvisart, Laennec, Dupuytren, Bichat, Pinel, Broussais, Louis, and Andral formed a circle that drew physicians from across the world. In the 1830s alone, hundreds of American doctors came to study there. The hospitals were crowded, the opportunities abundant. Paris had many hospitals and many thousands of patients, and the Hôtel Dieu alone held enough beds to turn suffering into a large and difficult classroom. The city was not just a place where ideas were announced. It was a place where methods had to survive contact with the crowd. Pierre-Charles Alexandre Louis turned that crowded world into a discipline of records. He had already practiced in Odessa and been troubled by the deaths of children with diphtheria. When he returned to Paris, he attached himself first as a voluntary helper to Chaume at La Charite, and then as chef de clinique. For years, he gave himself to the wards and the post-mortem room. He occupied a room in the hospital's upper level and filled it with notes. That sort of life leaves little room for display. It leaves room instead for patience, comparison, and the refusal to let one impression stand in place of many observations. Louis's method was systematic. He tried to learn the patient's earlier health, age, occupation, residence, family background, and manner of living. He followed the current illness in detail, keeping the sequence of symptoms clear. He separated what the patient said from what the physician found. He recorded the course of the illness carefully. If the patient died, he sought a post-mortem and recorded the findings there as well. What emerged was not simply a story, but a structure. A case could be revisited, checked, and compared with later cases in the same book. He also tried to arrange cases numerically so that one group receiving a therapy could be set beside another that did not. When he compared bloodletting in pneumonia, the result was not flattering to a popular practice. Critics objected, as critics often do when authority has to make room for evidence. Louis answered them in effect by putting precision on one side and vagueness on the other, and insisting that medicine had to choose. That insistence did not end controversy, but it changed the standard. A physician could no longer rely on confidence alone. He had to show the path by which he reached a conclusion. Louis was not working alone, and he did not create the French school by himself. Martinet's manual shows how widely the method had spread. He told the observer to stay calm, hear the patient carefully, write the case down immediately after the visit in a book kept for that purpose, and begin with name, sex, age, and occupation. In some cases, he asked for the district the patient came from and the diseases common there. He also treated acute and chronic illness differently and gave separate methods for the brain, chest, and abdomen. The page became part of the examination itself. The same school depended on a larger crowd of workers than the famous names suggest. Students filled the wards. Visitors came from America and other countries. Assistants copied notes, made sketches, followed the post-mortem, and carried what they learned into new hospitals. The habits of Paris did not remain in Paris. They rode home in notebooks, in spoken stories, in published manuals, and in the memory of men who had seen how a hospital could become a place of method rather than confusion. The French school also sharpened what medicine expected from a teacher. It was no longer enough to have opinions at the bedside. A physician had to show the patient, the notes, the sequence, and the outcome. That expectation is one reason the period matters so much. It produced clinicians who were also record keepers, and record keepers who were also interpreters. The page and the ward began to depend on each other. One without the other left the work unfinished. By the 1840s, though, the French model had reached its limit. Careful observation and post-mortem confirmation had done a great deal, but they could not by themselves explain every cause or mechanism. The center of gravity moved toward Germany, where the laboratory grew more important. Johannes Müller stood at the center of that shift. The questions were changing. Not only what did the disease look like, but why did it happen, what made it move, and what hidden process could account for its course. The old and the new were not enemies, they were stages in a longer chain of work. Vienna kept that chain visible. Rokitansky and his assistants performed autopsies in astonishing numbers, nearly 60,000 over the course of his career. Skoda became known for his skill in physical diagnosis. Hibra and his pupil Kaposi linked skin disease with pathological anatomy. Semmelweis, also in Vienna, took a hard lesson from the labor room and insisted that physicians wash their hands before attending women in childbirth. These names belong to different rooms, but they belong to the same habit. Each one asked the body to answer under conditions that could be repeated and checked. When the center of medicine later shifted in America, the pattern changed again, but the labor remained human. The reforms at Harvard, Pennsylvania, and Michigan prepared the way for Johns Hopkins. There, the medical clinic gave students a new role. Residents lived in the hospital. Students took histories, performed physicals, did laboratory work, and made rounds with residents and faculty. The student was no longer only a listener at the edge of the room. The student became part of the patient care team, and that change mattered as much as any single instrument. William Osler made that model feel complete because he understood both the laboratory and the bedside. He had a reverence for the clinicians who came before him, and he also understood that training had to be active. The clerkship did for clinical students what laboratory work did for scientists. It taught them to carry work, not merely watch it. That was the deeper inheritance of the period, a medical culture in which people learned by doing, recording, comparing, and returning. So the story is not only one of famous discoveries, it is also a story of wards and notebooks, of students who arrived from far away, of assistants in hospital rooms, of teachers who kept moving between the bedside and the post-mortem table, and of patients whose illnesses became part of a larger discipline because someone stayed with the details. Medicine advanced when enough people were willing to make the same case visible in more than one place, and to trust the record as much as the first impression. In the next rooms, the measurements would become finer, and the limits would become clearer. For now, the essential work has already been done by hands that wrote, carried, listened, and checked. That carrying did not stay abstract. In Leyden, Boerhaave gave his students 2 small wards and a fixed route through them: the history, the inspection, the urine, and then the autopsy when death made the answer available. In Padua, Morgagni turned those answers into a library of cases, each one tied to the findings in the body and indexed so the next physician could compare one illness with another. Anbrugger then asked a different question. Instead of waiting only for the autopsy room, he listened at the chest itself, finding that a tapped rib cage could tell him something about what lay beneath. Corvisart gave that idea authority by testing it again and again on the wards, and Laennec carried it further still, shaping a simple tube into a new way of hearing. He was not only listening, he was training a generation to connect the sound, the symptom, and the anatomy found later. By the time Paris became the center of medical study, the hospitals were crowded with patients and crowded with students. That crowding mattered. It meant that disease could be seen in numbers large enough to compare, and Pierre Louis used that chance to make the clinical case systematic. He asked for the previous health of the patient, the course of the illness, the findings of examination, and the record of what happened next. If the patient died, he wanted the autopsy too. He also pushed medicine toward numbers, comparing groups of cases instead of trusting habit alone, and showing that a treatment as familiar as bloodletting could not be accepted just because it was old. Then the center shifted again. German universities made the laboratory part of medical education, and American physicians went there in large numbers to learn what the French schools had not emphasized enough: the causes and mechanisms of disease. When they returned, they brought back microscopes, thermometers, ophthalmoscopes, sphygmomanometers, and, later, X-rays, tools that made the hidden measurable. The ward was no longer only a place to observe, it was a place to test. The patient's body could be read with new instruments, and the findings could be set beside pathology, physiology, and experiment. At Johns Hopkins, Osler gathered those threads into a single way of teaching. Students were not left at the edge of the room. They became part of the team, taking histories, examining patients, doing laboratory work, and rounding with residents and faculty. The clerkship made learning active, and that changed the shape of medical training. It made the student responsible for the case, not just aware of it. It made the notebook matter. It made the bedside, the lab bench, and the post-mortem table parts of the same path. That was the larger inheritance of the age. Medicine advanced because people kept moving the case forward without breaking its chain. A sound heard in the ward could be checked later against anatomy, then turned into a lesson, then tested again in another hospital, by another hand, on another patient. The work was carried, and because it was carried carefully, it could be shared. That chain depended on more than goodwill. It needed materials that could keep a fact still long enough for another person to examine it. A notebook did that first. Then came the tally, the scale, the tube, the plate of glass, the column of mercury, the brass fitting, the ivory disc, the rolled sheet of paper, and the room where the record could be compared to a body and then to a post-mortem finding. Pierre Charles Alexander Louis understood that the case had to be made repeatable. In Paris, he listed cases in numerical order and compared one group with another, not because numbers were magic, but because a physician who wanted truth had to be able to distinguish it from mere vagueness. Exact observation could be argued with. A loose impression could not even be defended. Paris offered him enough material to make that discipline visible. The wards were crowded with acute and chronic disease, and the hospital had become the place where medicine could gather an amount of human illness that earlier generations never had before. Tens of thousands of people moved into the capitals with industrial life, and many had nowhere else to go when they were sick. In practice, the 19th century became the century of the hospital. The hospital was no longer only a refuge, it was also an engine of comparison. In one city there were 30 hospitals and 20,000 patients. The Hôtel Dieu alone held 1,000 beds, and thousands of medical students moved through those rooms looking for cases. Abundance gave the clinician a wider field, but it also set a trap. A flood of material can make a doctor careless if the record is not firm enough to keep each observation in place. Louis answered that problem by living almost entirely inside the ward and the post-mortem room. For years he worked under Chomel at La Charité, occupied a room above the main floor of the hospital, and set himself to rigorous observation. Private practice fell away. The case became his main object. He looked at the patient's previous health, family history, occupation, residence, and manner of living, then at the course of the illness itself, then at the findings at autopsy if the patient died. That sequence mattered. It kept the bedside from drifting away from the body on the table. He also used the order of cases to test treatment, comparing one group with another. His work on pneumonia showed that bloodletting was uncertain in value. Critics attacked the numerical method, but the deeper lesson remained. A clinic needed methods that could survive disagreement. That same impulse appears in Martinet's manual, where the page becomes another kind of instrument. He began with the patient's name, sex, age, occupation, and sometimes the country or district from which the patient came, and the illnesses common there. Acute and chronic disease required different kinds of narration. Absences mattered as much as presences, because an omitted sign could make an observer look careless. The notes had to be written immediately after the visit in a book kept for the purpose. The book was not decoration, it was a guarantee that the case could be carried forward without being rewritten by memory. Even the order of the entries mattered. The report had to present the facts in the order they appeared, like a faithful copy rather than a loose story. Long before the great hospital schools of Paris, Boerhaave had already made the bedside a classroom, but his room was still small enough to be counted. 2 wards, one for men and one for women, held 6 beds each. On those 12 beds, half the physicians of Europe were said to have been trained. His students made daily rounds, questioned the patient, examined the urine, and then went to the autopsy table when death came. The body was still approached through what could be seen and handled, because percussion and auscultation had not yet entered the room. The limits of that older bedside medicine were real. Without a way to hear or tap the hidden organ, the clinician had to rely on the visible surface, the pulse, and the excretions. Still, the routine was already forming. Bed, question, inspection, record, dissection, return. Percussion gave the surface a new authority. Onbrugger learned to listen with the hands, using the chest as a resonant chamber. He recommended a gloved hand or a tight shirt between skin and fingers, and he compared healthy sound to a muffled drum. Corvisart revived the method on the wards and gave it prestige. Then Priori pushed the idea further. He invented the pleximeter, an ivory plate between finger and skin, so that the note could be made clearer and the touch less painful. On his stool, he moved from bed to bed, mapping organs on the skin with colored crayons until the torso looked like a chart. The method was exact and theatrical at the same time. It promised to localize disease during life, but it still depended on the skill of the listener. A sound could suggest a region, it could not explain itself. Laennec turned that same need into a tube. The story begins with a courtyard, children, and long pieces of wood that carried sound from one end to the other. At the Necker Hospital, he rolled a sheet of paper, tied it with string, and placed it on a diseased heart. The first stethoscope was a temporary thing made from the simplest materials at hand. Later, he refined it into wood, then into a 2-piece instrument that could be carried more easily, and he gave copies of the book to readers with a stethoscope included. He worked out the details at the bedside, in the wards, and then at the post-mortem table, speaking at the bedside and following with the anatomical findings that confirmed or corrected what had been heard. Direct auscultation had already shown its limits. It was awkward for physician and patient alike, and in hospital practice it could be impractical. The new instrument made listening possible where direct contact was difficult, but it also created a new burden, sounds that had to be named before they could be understood. The vocabulary of chest disease had to grow with the instrument itself. By the 1890s, the stethoscope had already become flexible and binaural, and later a diaphragm was added, because the object kept being revised as the act of listening kept revealing its own limits. Temperature measurement followed a similar route from rough device to disciplined scale. Thermoscopes had existed in one form or another since antiquity, but they were not yet thermometers. Galileo's little joke used alcohol to mark change in the air. Sanctorius adapted a device for patients, asking them to keep the bulb or breathe into it so that a change might be read as a sign of prognosis. In Florence, the thermoscope was sealed away from atmospheric pressure, and even then, there was still no agreement on scale or substance. Some used alcohol, Newton used linseed oil, and the 0 point itself shifted as the scale was worked out. By the time clinical thermometers were common, the question had changed. Temperature was no longer a rough guess about climate. It became a pattern across the course of disease. Wunderlich gathered notes from 25,000 patients and millions of readings. He showed morning remissions, evening rises, and the characteristic curves of different illnesses. The thermometer gave something stubborn and exact. Heat could not pretend to be other than it was. But even then, it remained one sign among many, telling the doctor how the illness moved, not why it began. Helmholtz found a different limit in the eye. The problem he set out to solve was not first a disease problem at all. It was the strange behavior of light in the pupil, dark under ordinary conditions and red under others. To answer that puzzle, he put his own eye in line with the rays and built a reflector from 3 plates of glass. The first ophthalmoscope was a small assembly of microscopic cover glasses and cardboard glued together, hardly a grand machine, but it let him see the retina in detail for the first time. He later described the instrument as a way to look into the dark background of the eye. It opened the internal structures of the eye to inspection while the patient was alive, where they had often been unknown even after death. The early device was soon improved into something more convenient, but its history shows how often medicine begins with an optical problem and ends with a clinical one. It also shows the limit of simple looking. An instrument can make a hidden surface visible without yet telling what the whole disease means, and it can wait years for ordinary physicians to take it seriously. Some tools traveled between specialties because the body did not keep its categories neat. The percussion hammer came from chest diagnosis and became a reflex hammer. The story runs from cowherds who struck animal heads and listened for resonance, to Wepfer, to Van Swieten, to the old Vienna school, and then back into neurology. By the late 19th century, Gowers was speaking of the knee jerk, and triangular hammers and brass wheels on bamboo sticks appeared in clinics and consulting rooms. The object changed shape as the diagnostic question changed. Once again, the material was simple, but the relation between hand and body had to be learned. A tap could tell the physician that a reflex was present or exaggerated. It could not, by itself, explain the disease that made it so. That was the pattern across these instruments. Each one sharpened a single line of inquiry and left the rest to judgment. Blood pressure measurement made that pattern even clearer. About 1733, Stephen Hales made the first measurement of blood pressure. He was a clergyman, but also a careful experimenter. In a horse experiment, he inserted a brass pipe into an artery and attached a glass tube 9 feet long. The blood rose high in the tube, and later Poiseuille replaced the glass with a mercury manometer. Ludwig added a float recorder and a chemograph, turning the rise of pressure into a trace that could be studied later. But direct arterial measurement was not suitable for ordinary clinic life, so others tried to find a way around the problem. Vierort used weight to see when the pulse disappeared. Von Basch used a water-filled bulb and a manometer. Hotain moved to air in the armband. Riva Rocci finally described the familiar rubber bladder and mercury manometer. The path from artery to arm was long because the body resisted easy measurement. What could be studied in the laboratory had to be made usable at the bedside, and that translation took decades. The same tension between laboratory and ward shaped the French and German schools. French medicine had mastered observation, autopsy, and the crowded hospital, but by the 1840s that method had reached its ceiling. The causes and mechanisms of disease still demanded experimental work, and that work belonged increasingly to the German university, with its laboratories, its flexible organization, and its free flow of inquiry. The shift was not immediate triumph. The first gains from the laboratory were modest, and no major therapeutic revolution arrived with them. What changed first was understanding. Physicians began to see that scientific information was not a sideline to practice, but part of what a modern doctor needed to know. Students crossed borders to learn it. About 15,000 American physicians went to Germany, Switzerland, or Austria between 1870 and 1914. Knowledge had become a route as well as a result. carried from one university to another and from one generation to the next. So the materials stayed humble and the ambitions kept growing. Paper, wood, brass, ivory, cardboard, mercury, rubber, and air were enough to change medicine, but none of them worked alone. Each tool exposed one part of the hidden body and left another part in shadow. Each method needed a notebook to keep it, a ward to test it, an autopsy to answer it, and a teacher to keep it from becoming a trick. That is why the limits mattered as much as the discoveries. They forced medicine to become orderly, comparative, and self-correcting. A sound heard in the chest could be checked against anatomy. A temperature curve could be set beside a course of illness. A map on the skin could be tested by what lay underneath: a brass tube, a glass column, a folded sheet of paper, a plate of glass. All of them were small things. What they opened was larger, a habit of asking the body a question in a form that another physician could repeat. Later, the X-ray would carry that habit one step further, but the discipline was already there. Count, compare, listen, and measure, while remembering that no instrument finishes the work by itself. On a narrow table at the end of the ward, the admission ledger sat beside the day's bed list. That book mattered because the hospital had become the place where medicine could gather its work, not one patient at a time, but many patients under one roof. A doctor could move from bed to bed, from note to note, from a fever chart to a casebook, and compare what was seen in one room with what was seen in the next. The hospital did not replace the bedside, it changed the scale of the bedside. Here, illness no longer lived only in private houses or distant visits. It entered a shared routine of rounds, records, and return visits. In that setting, listening and measuring became habits that could be repeated by students, nurses, clerks, and physicians alike. The ward turned diagnosis into a discipline that could be watched, corrected, and taught. The change was tied to the movement of people into cities. Industrial Europe drew thousands from the countryside into crowded capitals, and many of those newcomers had no family nearby when sickness came. For them, the hospital was not a grand institution first and a refuge second. It was simply the only place that could receive them. The wards filled with acute infection, long illness, and the ordinary damage of poverty and crowding. Paris showed the new scale especially clearly. By 1830, Paris had 30 hospitals, 20,000 patients, and 5,000 medical students. The Hôtel Dieu alone held 1,000 beds. Physicians and students could see whole series of cases, not just scattered examples. That mattered. A single encounter could be mistaken. A row of similar cases could teach pattern, variation, and consequence. The hospital made illness visible in numbers, and numbers changed practice. Paris was not isolated from the rest of thought. It was also a center of mathematics, physics, chemistry, and biology, and that habit of exact work spilled into medicine. The French hospital system gave that new visibility a form. Paris became the place where medicine drew visitors from across Europe and from America as well. The city was not only full of patients, it was full of teachers, observers, and young physicians trying to learn a more exact way of working. The political climate helped too. Physicians had status, Napoleon encouraged them, and Corvisart stood close to power. In those crowded wards, a doctor could ask for the kinds of cases he wanted to study. The hospital was no longer simply where the sick waited, it was where disease could be sorted, followed, and compared. The practice that grew there depended on close observation, on the autopsy, and on the belief that the story of illness could be traced from bed to post-mortem room. That link between the living patient and the dead body changed the meaning of the ward itself. There was already a hospital tradition behind that development. In Leyden, Herman Boerhaave had been given 2 small wards in an old hospital, one for men and one for women, and from those 12 beds, a remarkable number of European physicians learned their craft. His students came on daily rounds. They heard the history, watched the inspection, and saw the urine examined, and when a patient died, they were sent to the autopsy. Boerhaave understood that the dead body could answer the questions the bedside had raised. The point was not spectacle, it was continuity. A note made in the ward had to meet a finding in the body. or the physician, remained uncertain. That habit, carried from ward to autopsy room, became one of the pillars of hospital practice. The hospital was teaching medicine to connect what was heard, what was seen, and what was found after death. In Paris, Pierre-Charles Alexandre Louis pushed that habit further. He worked for years at La Charité and at the Children's Hospital, keeping himself close to the wards in the post-mortem room. He became known for the discipline of his notes. The patient's earlier health, occupation, residence, family background, and manner of living all mattered to him. He wanted the present illness in sequence, how it began, what followed, what changed, and what the physician could observe directly. When the patient died, the autopsy was not an ending, but part of the same investigation. Louis was among the first physicians to compare cases by number, grouping them, and weighing one course against another. That allowed him to question treatments that were popular but uncertain. The hospital, in his hands, became a place where medicine could test itself. A single impression was no longer enough. The ward book, the bedside, and the autopsy report had to agree, or the claim remained weak. Louis also helped turn the case itself into a formal object. His method was not casual recollection. It was an ordered record. The earlier state of health came first, then the details of the present illness, then the signs found in the patient's own account and in the physician's examination, then the course of the disease, and finally, the autopsy, if death came. That sequence gave later physicians a model for writing about illness in a way that others could follow. It also showed that the hospital note was not just a clerical task. It was part of diagnosis. The pages in the book had to preserve the order of events, because order often carried meaning. What happened first, what changed later, what never appeared, and what was discovered after death all belonged to the same chain. In this setting, careful writing became a medical tool, as important as the hands that tapped or the ear that listened. A little later, Martinet gave that same habit a practical handbook. His advice treated the bedside as the place where disease appeared most clearly, stripped of the distortions that books could introduce. He urged physicians to stay composed, to listen closely, and to write the case in a form that would let another reader see the facts in the same order they had appeared. He wanted the leading symptoms first, the sequence preserved, and even the absence of expected symptoms noted down when it mattered. The observations were to be entered immediately after the visit in a book kept for that purpose. He began with the patient's name, sex, age, occupation, and sometimes the region from which the person came. Chronic disease demanded more background than acute disease. The brain, chest, and abdomen each needed their own method of examination. Inspection, percussion, palpation, and auscultation were all part of the routine. The result was a hospital method that could be repeated, taught, and checked. Not every physician worked in the same way, and the hospital did not erase differences overnight. Some doctors preferred to look long before asking anything, and others gave the patient more room to speak. But the larger current was moving toward exact observation. By the middle of the 19th century, the French school itself began to lose its unchallenged position. One reason was simple. The hospital, for all its power, could show where disease sat and what it had done, but not always why it began or how it worked. Observation and autopsy had reached their limit. To go further, medicine needed physiology, chemistry, pathology, bacteriology, and experiment. The center of gravity shifted toward Germany, where universities and laboratories had room for that kind of work. For many young physicians, the next journey was not across a city, but across an ocean of ideas. They went to the laboratory because the ward alone could no longer answer every question. That shift mattered in the United States. Before the Civil War, American medical education was often thin, commercial, and mostly didactic. Admission to many schools depended less on ability than on whether a student could pay. Anatomy might be taught without dissection. The faculty was often small, and research was not part of the job. The war exposed the weakness of that system with painful clarity. Many soldiers died of disease, and the Army and Navy required physicians to pass a compulsory examination, which only about a quarter managed. Yet the hospital also offered one of the few paths to better training. Apprenticeship, summer schools, and the house pupil system gave some young doctors a chance to learn with real patients. For a student who wanted more than lectures, the ward could become the first serious classroom. The bed, the thermometer, the stethoscope, and the notebook started to belong together. The reformers who returned from Germany found an American landscape that was ready, if only reluctantly, to change. Harvard moved first in a decisive way. Charles Eliot, trained in science and shaped by work in the laboratory, pushed the medical school toward laboratory teaching and against the old habit of pure lecture. Henry Bowditch, newly returned from German physiology, became the first medical professor in America to keep a full-time appointment in teaching and research. The laboratory became the center of a broader science curriculum, and the goal of medical education changed with it. Students were no longer expected only to memorize a set of facts. They were expected to think, to solve problems, to find new information, and to keep pace with change. Pennsylvania and Michigan followed with reforms of their own. Medicine was moving into the university, and the university was beginning to claim responsibility for medicine. That was a practical change, not just an administrative one. It changed what a student had to do on an ordinary day. Johns Hopkins made that new arrangement unmistakable. From the start, the school set strict admission standards, offered 2 years of rigorous basic science with laboratory work, then 2 years of clinical experience at the hospital bedside. It chose faculty for their teaching and research ability, and it treated research as central rather than optional. William Osler's arrival as head of medicine gave the institution a guiding mind that connected all these pieces. He respected the work of earlier clinicians, but he also understood the value of the laboratory and the pathology room. In his clinic, residents lived in the hospital and moved through graded levels of responsibility. Students did histories, physical examinations, and laboratory work, and they made rounds with residents and faculty. The clerkship made the student part of the patient care team. Surgery, obstetrics, and gynecology were drawn into the same model. The hospital was no longer only a place where medicine happened, it was a place where medicine was made. The tools changed along with the rooms. A thermometer no longer sat as a curiosity on a shelf. It entered the ward routine. A careful pulse count, a blood pressure reading, a physical examination, and a written note all began to belong to the same visit. Each new device was valuable only because it could be folded back into the hospital habit of observation, recording, and comparison. The point was never the object alone. It was the route from patient to note, from note to teaching, from teaching back to the next patient. In that route, the hospital became a collection of repeated actions. A chart opened, a bed visited, a result written down, a colleague shown the page. Medicine changed because the room changed, and because the room made repetition possible without losing the individuality of the person in the bed. By then, the ward had changed in a deeper sense. It was a place for receiving the sick, but also for training the hand, the ear, and the eye in common method. It was a place for keeping faith with the casebook, for comparing one course with another, for matching the bedside with the autopsy, and for joining the bedside to the laboratory. The routine of the daily ward round, once a narrow habit, had become a way to organize knowledge itself. A doctor could not be satisfied with a single impression when the room held many beds, many notes, and many chances to compare. The hospital did not solve medicine. It gave medicine a larger memory, a firmer order, and a discipline that could be handed from one generation to the next. In that order, the patient remained central, but the patient was no longer seen alone. The case was now part of a shared practice that would keep expanding into records, teaching, and public understanding. The hospital's new order depended on ordinary patients, beds checked, histories heard, charts filled, autopsies reviewed, students corrected. No single method replaced the others. The old listening never vanished. It simply found itself living beside new rooms and new papers. That was the change. Medicine learned to listen in a building where listening could be tested, written down, and taught again the next day. The next room was smaller than the ward, but it carried its own gravity: a narrow desk, a blotter, a stack of case sheets, and a ledger opened flat under a lamp. In that room, listening did not end when the patient stopped speaking. It changed shape. What had been heard at the bedside was carried to paper, arranged, compared, and made available to someone who had not stood in the same doorway. A good case note was not a memory preserved against forgetting. It was a way of making observation durable enough for another physician to follow later. The page asked for order. It began with the patient's name, sex, age, and occupation. In some cases, it also asked for the place of origin, or the district from which the patient came, because disease did not always sit still in one body, and one body did not always live apart from climate, work, water, and the common illnesses of a region. The course of the complaint had to be set down in sequence: what came first, what followed, what changed, what stayed absent. Absence mattered too. If a symptom usually appeared and did not, the omission itself could be useful, so long as it was not hidden by carelessness. Such records were meant to be written while the visit was still fresh. The hospital note could not depend on a soft recollection hours later, after the smell of the ward had faded and another case had already crowded the first out of mind. The record was not only for the writer, it was for the next reader, and for the next day, and for the moment when a teacher would ask how the story had been told. That pressure made the note sharper. It did not let the physician drift on habit alone. Before that discipline became common, pathology had already shown how much a written account could matter. The autopsy did not replace the bedside. It gave the bedside a second hearing. In the older collections of cases, the histories were kept beside the post-mortem findings, arranged and indexed so the living signs could be laid against the dead body. That pairing gave medicine a new kind of memory. A case was no longer only an event that vanished when the room emptied. It could be read again after death, and the reading could alter what was thought to have been seen in life. That habit reached beyond the hospital walls. Families sometimes wanted an autopsy on a relative in order to know the cause of death. Authorities in public hospitals could allow it. In that willingness, there was a kind of civic faith. The body of the dead was still being asked to teach, and the family was often willing to have the lesson made. The physician had to answer not only to a private conscience, but to a public desire for explanation. Cause mattered. So did proof. The dead were not only mourned, they were consulted. The same impulse shaped the early teaching wards. Boerhaave in Leiden made bedside instruction into a method. 2 small wards, one for men and one for women, became a school for students who came from across Europe. The daily round was plain enough: history, inspection, urine, and later the autopsy. When death followed, there was little theater in it. The power lay in repetition. A handful of beds could train a generation if the same habits were returned to each day with care. The bedside became a classroom because it was treated as a place where observation could be checked and corrected. When the scene moved to Paris, the scale changed, but the principle did not. Laennec demonstrated chest signs in the wards at the Necker Hospital, then moved to lecture, then to the post-mortem room, where the signs were matched against the body. Students took notes, some made sketches. Many came from outside France and carried the method home with them, along with stethoscopes made from the new instrument he had shaped for himself. The ward, the lecture room, and the after-death room formed a chain. One room gave the sound, another gave the explanation, and the page kept the link intact. The stethoscope itself became part of public trust. Within a decade, physicians felt they had to use it or risk their reputation. That is a striking sign of how a practice moves from novelty to expectation. A rigid tube gave way to more portable forms, then to flexible binaural instruments, and eventually to a device that nearly every physician knew how to wear. The object did not create authority by itself. It marked a discipline already underway. To the patient, it said the doctor had learned to listen in a manner that could be taught, repeated, and checked against other cases. Paris had the conditions for this kind of medicine. It was crowded with hospitals, students, and patients. The cities of Europe were filling with people who had left the farms and had nowhere else to go when illness came. Tuberculosis, typhoid, and other chronic and acute diseases filled the wards. In that setting, the hospital became more than a refuge. It became a place where illness could be seen in quantity. Physicians could compare one case against another. They could choose the kinds of cases they wanted to study. The crowding that burdened the city also gave medicine an enormous field of observation. Pierre Louis made that field into a discipline of its own. He was not satisfied with impression alone. He asked about age, occupation, residence, family history, and way of life. He followed the illness in sequence. He recorded the course of the disease carefully. If the patient died, he pursued the autopsy and wrote that down too. His method turned the case into a numbered and ordered object of study. That allowed him to compare groups of patients and test treatments against one another. When bloodletting was praised for pneumonia, he used exact records to show how uncertain the practice really was. Lewis understood that vagueness and truth did not belong together. He trusted exactness, not because it was tidy, but because it could be checked. A case written with care could be revisited. A group of cases could be counted. A result could be compared against another result. The physician's notebook ceased to be a private scrap of impressions and became an instrument of judgment. That change mattered for teaching as much as for treatment. Students learned that a strong opinion was not enough if the page could not support it. The French hospital method had limits, though. Observation and autopsy could reveal a great deal, but they did not by themselves explain the causes and mechanisms of disease. By the middle of the 19th century, the center of gravity began to shift toward the German universities, where laboratory science took a stronger place beside clinical work. The shift did not erase the hospital. It asked for a new alliance. The body seen in the ward still mattered, but now its signs were being read alongside experiments in physiology, pathology, chemistry, and related sciences. Across the Atlantic, American medicine had its own problem. In the years before reform, many schools were still built on lectures, not on disciplined apprenticeship. Admission could be little more than a question of whether the student could pay. Anatomy was often taught without dissection. Research was not part of a faculty member's duty. The school was too often a commercial arrangement, with little obligation to the slow work of observation. In that setting, the case record and the bedside lesson had even more importance, because they offered a way to bring rigor into a loose system. The reform came through universities that were willing to change what medical education was supposed to be. At Harvard, Charles Eliot pushed the school towards science with laboratories. Henry Bowditch became the first medical professor in America to devote himself full-time to teaching and research. The laboratory became a place for learning how to think, not just how to recite. Pennsylvania and Michigan followed. The larger idea was simple and severe. Medical training should not merely fill a student with facts. It should form a mind capable of returning to new evidence and working through a problem without drifting. Johns Hopkins carried that idea into the clinic. Its medical school demanded stronger admission standards, more serious basic science training, and clinical experience at the hospital bedside. Osler's clinic made the student an active participant. The residents had graded experience. The students took histories, performed physical examinations, did laboratory work, and rounded with the staff. The clerkship emerged from that structure. A student no longer stood at a distance while others worked. The student entered the work and learned by doing it under supervision, case by case, day after day. That mattered because trust in medicine was increasingly tied to visibility. A teacher who could show how a history was taken, how a finding was weighed, and how the next step followed had more to offer than a teacher who simply declared an answer. The ward had become a place where method could be seen in action. The patient's story was not hidden. It was shaped into something others could inspect. The public did not see every page, but the culture of medicine was changing in a way that made its reasoning more accountable. By the early 20th century, the record itself was becoming a source for teaching. Hospital notes could be studied afterward, and the medical interview could be inferred from them. Richard Cabot's case, teaching preserved detailed histories, though often only a line or two about the patient's social circumstances. That detail is small, but it matters. It shows a transition from a medicine that treated the body as isolated to a medicine that noticed where the patient lived and worked. Even so, the era still lacked formal textbooks on history-taking. Senior physicians taught by example at the bedside, and students were rarely observed or corrected in a systematic way. That absence says something important. The craft of listening was still partly embedded in the room itself. It was passed from physician to student through posture, timing, patience, and repetition. The page helped, but it did not yet rule. Questions in manuals were often specific and narrow, and social life received only limited attention. The interview remained a practice of encounter more than a fully articulated syllabus. What counted was not simply that a question got asked, it was how the question fit the patient, the setting, and the rest of the case. The result was a medicine that increasingly had to answer to more than one audience. A patient heard the physician's voice, a teacher read the notes, a student watched the method, a pathologist checked the body later. A family could ask for explanation, a hospital could preserve the record. Each of those listeners exerted pressure on the others. The work became more public without ceasing to be intimate. The case was no longer owned by a single pair of hands. A good record made that possible. It held the sequence of the illness. It kept the patient's age and work and place. It kept what was found and what was not found. It could be brought back to the ward, to the lecture room, and to the post-mortem table. It could outlast a moment of fatigue or confusion. It could correct memory when memory grew careless. That was part of how medicine earned confidence. The physician was no longer asking the world to trust a private impression. The physician was offering a trace that others could examine. So the day's listening did not disappear when the lamps were lowered. It settled into books, case sheets, and hospital files. A morning round could be read in the afternoon. A bedside judgment could be tested against a later finding. A student could open the same page and hear the case again in a different key. That is how medicine gained a more durable voice. It learned to speak in records and to teach from them, and to let the public see enough of the process to believe that the hearing had been done with care. The page was not only a memory aid, it was a restraint on careless impression, a case that could be entered in order, reviewed in sequence, and compared with the body after death became something more durable than a recollection. In Paris, the best clinicians taught that the observation should be written down as soon as the visit ended, while the details were still warm in the mind. The patient's name, age, occupation, and place were put at the top. Then came the complaint, the course of the illness, the findings of the exam, and the absence of what might have been expected, but was not there. Even the silence had to be recorded. That habit changed the ward. It meant that the bed was no longer only a place where suffering appeared and vanished. It became a site of repeated study. The same patient could be seen by the teacher, the student, and the pathologist, and each could refer to the same written trace. A note in the casebook could be carried from the bedside to the lecture room, and then to the post-mortem room, where the final proof either confirmed the judgment or corrected it. In that exchange, medicine gained a kind of honesty that was visible to others. The French hospitals made this possible by gathering illness in numbers large enough to study. Crowded wards, busy services, and long series of cases gave physicians a scale that earlier generations had never known. Louis turned that abundance into method. He read the patient's story closely, followed the sequence of symptoms, and insisted on careful records and autopsies. His work showed that diagnosis was not a flash of genius but a disciplined way of comparing one observation with another. What he taught at the bedside soon became a model. Students were not meant to stand at the edge and admire the master's certainty. They were meant to ask, to note, to examine, and to return to the record. Later, in the American hospital, that same spirit reappeared in the case teaching of Richard Cabot and in the clerkship at Johns Hopkins, where students took histories, did physical examinations, and became part of the work itself. medicine learned that trust did not come from authority alone. It came from the habit of showing one's work, one careful line at a time. When the formal round ended, the ward did not truly end its work. The residents lived under the same roof, the casebook still needed its entries, and the next hour had to know what the last hour had found. In that setting, ordinary care was not a minor duty. It was the steady chain that held the whole hospital together. The building had become a place where disease gathered in numbers, where one patient could be compared with another, and where a careful note could matter as much as a strong opinion. That change came with the growth of cities. As people moved into crowded capitals, hospitals became the one place many sick people could go. The room with the beds, the shelf with the books, and the table with the notes all began to matter in a new way. The older bedside habits had already pointed the way. Boerhaave taught in a small ward at Leiden, with men on one side and women on the other, and he made daily rounds with students who reviewed the history, inspected the patient, and examined the urine. When a patient died, the students went to the autopsy that joined the living bed to the dead body and made the hospital a place of learning as well as shelter. It also gave medicine a rhythm that did not depend on one inspired moment. It depended on repetition, on return, and on the discipline of bringing what was seen at the bedside into the room where the dead were opened and studied. Then Louis carried that discipline into Paris and made it harsher, cleaner, and more exact. At La Charité, he worked for years in the wards and the post-mortem room, first as an assistant and then as chef de clinique. He lived in a small room in the hospital and filled it with notes. He was not hunting for dramatic cures. He was building a way of seeing disease in order. First came the patient's previous health, with age, occupation, residence, family history, and manner of living. Then came the illness itself, followed in sequence, not scattered. Then came the manifestations as they appeared in the patient's account and in the physician's examination. Then came the record while the disease was still in progress. If death came, the autopsy followed, with a careful account of what the body showed. The method was exact because the hospital demanded exactness. Louis also taught medicine to trust numbers. He listed cases in order and compared the patients who received a treatment with those who did not. Bloodletting, which had been widely used, could no longer hide behind habit. It had to survive comparison. That was a quiet revolution. The ward table was no longer only a place for opinion. It was a place where one row of cases could answer another row. Precision began to matter as a moral habit. If a physician was careless with the list, the argument became weak. If the list was honest, the treatment could be judged. Martinet turned those habits into a guide for daily use. He placed the bedside at the center and asked the physician to be calm, conciliating, attentive, and kind. He wanted the case to be written so carefully that it would preserve the facts as faithfully as a painted likeness preserves a face. He warned that if a symptom usually seen in a disease was missing, that absence should still be recorded because silence could look like negligence. He wanted the observations transcribed immediately after the visit into a book kept for that purpose. That book mattered. It protected the facts from forgetting. It made the visit portable. It allowed one doctor to hand what had been seen to another doctor without losing the shape of the scene. The same book began with the patient's name, sex, age, and occupation. Sometimes it also needed the country or district and the diseases common there. Martinet treated chronic illness and acute illness differently. In long diseases, the previous history had to be known in full because it might explain what was obscure. Then he moved through the body by region. The brain, chest, and abdomen each had their own method. The chest received inspection, percussion, palpation, and auscultation. The stethoscope came after percussion in his sequence. The skin, muscles, nerves, mucous membranes, joints, lymphatics, and veins also had to be observed. The hospital room was becoming a place of methodical attention, where the patient was not reduced to a single complaint and the physician was not allowed to rely on memory alone. Laennec gave that method another instrument. The stethoscope did more than make sound easier to hear. It joined the living bedside to pathologic anatomy and made the clinic and the autopsy table speak to one another. He worked it out at the Necker Hospital, and his book on mediate auscultation spread quickly through medicine. Students came from far away to learn it and carried the instrument home with them. The ward demonstrations were followed by post-mortem examination, so that what had been heard could be matched to what the body revealed later. The instrument did not remove the patient from the center. It made the patient's body more legible to the ear and gave the note in the chest a place in the written case. In the routine of ordinary care, a small tool could now shift an entire habit of diagnosis. The same was true for the growing respect given to autopsy. In several places, public hospitals and public authorities allowed post-mortem examinations on those who had died, and families sometimes asked for them. They wanted the cause of death known. Physicians wanted the chance to compare the story of illness with the structure of the body. That request for explanation helped bind the hospital to the public. The institution promised more than a bed. It promised an account. It promised that the end of a life would not vanish into rumor. It would be examined, recorded, and fitted back into medical understanding. By the middle of the 19th century, however, observation and autopsy were not enough on their own. Medicine needed to know causes and mechanisms, and that pushed attention toward the laboratory. German medical science showed that experimental methods could be used to study disease and therapeutics, not just the healthy state. What had once seemed like interesting knowledge for a few specialists began to belong to the ordinary practitioner. The hospital did not disappear in that shift. It remained the place where knowledge had to return. The science had to come back to the bed if it was to matter. Vienna showed that return in another way. Rokitansky and his assistants performed autopsies in astonishing number, building an immense store of pathologic knowledge. Skoda became famous for physical diagnosis. In the same century, instruments such as the thermometer, ophthalmoscope, and sphygmomanometer helped make the body measurable in routine practice. These were small objects, but they changed the ordinary work of the ward. A temperature could be compared from 1 hour to the next. The eye could be examined in a new way. Blood pressure could be taken as a number instead of guessed as a feeling. Measurement did not end uncertainty, but it made uncertainty more honest. The French hospital system had already shown how much could be learned when disease was brought together in large numbers. Paris drew physicians from far beyond France. Students came from America, and the wards offered a concentration of illness that earlier medicine had never seen. Overcrowding was not a virtue, but it did create a setting where the same disease could be followed again and again, where observation could be tested against repetition. That abundance of cases gave the hospital a new authority. It was no longer only a place for the poor or the dying. It was a place where disease could be studied in volume, and where the records on paper could grow thick enough to support comparison. In the United States, the distance between that model and the old one was still large. The Civil War exposed how uneven American medical training remained. Many physicians had little practice with percussion or the thermometer, and stethoscopes were uncommon. Instruction in many schools was mainly didactic. Anatomy could be taught without dissection, and research was not treated as a normal faculty duty. That world could turn out doctors, but it did not yet make the hospital the center of education. The pressure to change came from the gap between what medicine was becoming and what schools were still teaching. Harvard, Pennsylvania, and Michigan began to change that pattern, and Johns Hopkins pushed it farther. There, the curriculum was built around strict admission standards, serious basic science training, and long clinical experience at the bedside. The faculty were chosen for teaching and research ability. Osler's clinic turned those reforms into daily practice. The resident staff lived in the hospital, and their experience was graded from new graduate to senior resident. Instruction in history taking and physical diagnosis was emphasized with unusual seriousness. The student no longer stood outside the work. He or she became part of the patient care team, taking histories, performing examinations, doing laboratory work, and making rounds with the residents and faculty. The clerkship grew out of that arrangement and spread to other branches of medicine. Ordinary care became the ground on which students learned to be physicians. That was where the night work mattered most. A live-in resident staff meant the hospital could carry its care beyond the formal visit. Someone was there to see what changed, to check a sign again, to make sure a note was not left unfinished until morning. The patient's story moved from one set of hands to another, but it did not leave the building. It stayed attached to the bed, the record, and the round. The system did not depend on one famous consultant arriving for a brief look. It depended on people who remained close enough to notice the small differences that make a case understandable. In that sense, the hospital night was not a pause, it was part of the method. Richard Cabot's case teaching shows how that method entered the record itself. The histories were detailed, and the social circumstances were kept in view, if only briefly. The case no longer belonged to disease alone, it also belonged to the patient's life, work, and place. Hospital records became a second room where medicine lived, a room made of paper. A doctor could return to those records and see how the illness had been described, what had been noticed, what had been omitted, and how the facts had been arranged for others. That habit of writing made the clinical encounter shared rather than private. It gave the next reader a chance to verify the first observer's work. Ordinary care, then, was not ordinary because it was small. It was ordinary because it had to be repeated. A history had to be taken again. A chest had to be listened to again. A note had to be entered again. A body had to be compared with the record again. And when a patient died, the autopsy had to close the circle again. The hospital had learned to live by that return. Its rooms, books, instruments, and tables all served the same purpose: to keep the account faithful. By the time the long night came to an end, medicine had not conquered disease, but it had learned how to keep company with it, with more care, more patience, and more exactness than before. The work did not stop when the lamps were lowered. Laennec was still making his rounds at the Necker Hospital after dinner, moving from one patient to the next, listening in the wards, then carrying what he heard to the post-mortem room to see whether the body would confirm the ear. His students wrote while he spoke, and the notes were meant to outlast the noise of the day. The stethoscope, once a curiosity, became a habit so ordinary that physicians soon felt they needed it to keep their standing. It changed shape and length and finally became flexible enough to travel easily from bed to bed. But its larger effect was to make listening a learned routine. Paris gave that routine a home in crowded institutions. In 1830, there were 30 hospitals in the city, with 20,000 patients and 5,000 medical students. The Hôtel Dieu alone held 1,000 beds. That crowd made repetition possible. A physician could see the same illness in many bodies, compare the first night with the next morning, and compare both with the findings after death. Pierre Louis worked in exactly that setting. He kept a room in the entresol of Le Charrette, wrote down each fact with patient care, and studied disease where it lived, in the ward, in the record, and in the autopsy room. He asked for the previous state of health, for occupation and residence, for family history and manner of living. He wanted the opening symptom, the sequence that followed, the signs the patient gave, the signs the physician found, and the changes that came day by day. When the patient died, he insisted on the final record of the body. That insistence made the case into something repeatable. A later doctor could test the first account against the next admission, the next examination, the next post-mortem finding. Lewis even turned this habit toward treatment, numbering cases and comparing those who were bled with those who were not. The argument was no longer simply about skill or reputation. It was about whether the observed facts could stand against one another without favor. In that sense, the night shift was not a pause in medicine, but a second reading of it. What had been heard at the bedside had to survive the silence of the ward, the page of the record, and the evidence of the body. By the middle of the century, the center of gravity began to move again. The hospital still mattered, but now the laboratory, with its well-provided rooms and its free inquiry, promised new ways to explain what the wards had only shown. Biochemistry, physiology, pathology, bacteriology, and pharmacology drew medicine outward toward causes and mechanisms. Still, the older discipline remained inside the newer one. The doctor had learned to listen once, then to listen again, and to trust the account only after it had been checked against the next day, the next page, and the next room. In a narrow room beside the ward, a ledger lies open with its pages ruled and waiting. The entries begin in plain order: name, sex, age, occupation, sometimes the place a patient came from. Then the page turns to the story of what began first, what followed after, what stayed away, and what changed from hour to hour. That kind of book mattered because it kept the visit from dissolving into memory. It gave the doctor a way to return, compare, and correct. A case was not meant to vanish when the patient left the room. It was meant to remain legible and testable on paper. The page also held the patient in a larger frame than a single complaint. A person's work, household, and habits could shape the meaning of a fever or pain as much as the symptom itself. The old clinical writers had learned that disease had a course, not just a moment. So the note had to record sequence, not merely impression. It had to leave space for the early signs and for the silence around them. Even the missing symptom could matter, because medicine was always trying to decide whether a detail was truly absent or only forgotten. The discipline of writing forced the discipline of attention. If the page was one half of the method, the autopsy table was the other. The living visit and the post-mortem room formed a pair. A patient was questioned, inspected, and watched over time. If death came, the body answered back in another language. The findings at the table could confirm, complicate, or overturn what had seemed certain in the ward. That meeting of record and anatomy gave medicine a harder edge. It made the bedside less like a place of guesswork and more like the first step in a longer inquiry. The page did not end at the bedside. It carried forward into the room where structure could be checked against symptom. The crowded hospital of the 19th century gave that inquiry a new scale. As cities grew and people moved in greater numbers, the wards filled with illness in forms and quantities that earlier generations had not known. Tuberculosis, typhoid, and many other chronic and acute disorders pressed into the same buildings. Hospitals became places where one patient could be compared with another, and where a physician could see the same disease appear again and again in different bodies. The hospital was no longer only a refuge. It became a teaching ground, an archive of living cases, and a place where observation could be repeated under steadier conditions than the home visit allowed. Pierre Louis made that scale into method. He insisted on exact observation, careful chronology, and the systematic record of what happened in each case. He was among the first to use numbers in a serious way to test treatment. Instead of trusting a familiar remedy because it was familiar, he compared groups and asked whether the result actually changed. That did not make medicine cold, it made it accountable. The old habits of bloodletting and other popular therapies could now be measured against the course of disease itself. Exactness became a moral habit as much as an intellectual one. It was a way of refusing to let confidence stand in for proof. Along the wall of the examination room, the instruments extended the senses one by one. Percussion let the chest answer under the hand. The stethoscope carried sound from heart and lung into the ear. The thermometer fixed fever to a marked scale. The ophthalmoscope opened the eye to inspection. The sphygmomanometer gave pressure a number. Later, the X-ray brought a new kind of shadow onto a plate. These were not replacements for the older art, they were additions, each one giving the doctor another surface to listen across. The body did not become less personal because it was measured. It became more legible, one layer at a time. Then the center of gravity moved toward Germany. The university, with its freedom, flexible organization, and well-provided laboratories, offered a different setting for medicine. Science stood beside medicine rather than outside it. The study of physiology, biochemistry, pathology, bacteriology, pharmacology, and experimental inquiry became part of what a serious medical education was supposed to contain. The laboratory bench, the microscope, the glassware, and the notebook began to shape the physician's daily work. The aim was not only to recognize disease after it appeared, but to ask how disease worked at all. Medicine entered a period in which causes and mechanisms drew as much attention as signs and symptoms. Students and young physicians crossed borders to learn those methods. Many went to German-speaking universities and returned with altered habits of mind. They had seen a model of scholarship that valued experiment, correction, and the free use of evidence. The journey mattered because it changed the kind of doctor schools hoped to produce. The physician was no longer expected to be only a practical dispenser of inherited wisdom. He was being reshaped as a worker who could think scientifically, test claims, and keep up with new knowledge. The travel itself became a route of reform. Knowledge moved in trunks, notebooks, and trained hands as much as in books. In America, reform began to pull the laboratory into the center of medical education. Harvard, Pennsylvania, and Michigan all changed their schools in important ways. The laboratory was no longer a side chamber for demonstration. It became the place where students learned to reason, to investigate, and to think with discipline. One of the changes that mattered most was the decision to make teaching and research a full-time work rather than an occasional duty. That shift gave medical education a different rhythm. It no longer relied only on lectures and memory. It asked students to learn by doing, by handling problems directly, and by seeing knowledge as something still being built. At Johns Hopkins, the pieces were brought together with unusual force. The school required stronger admission standards, gave students years of basic science with extensive laboratory work, and then added years of bedside experience in the hospital. Faculty were chosen for their teaching and research ability. Research was not treated as an ornament, it was central. The school made room for both the experimental and the clinical, and that combination became a model for later medical education. The classroom, the laboratory, and the ward were made to support one another instead of competing for authority. Modern medicine did not come from one room. It came from several rooms made to speak together. Osler gave that arrangement its daily shape. In the clinic, resident physicians worked at different levels of experience. New graduates stood beside more seasoned residents. Students did more than watch. They took histories, examined patients, carried out laboratory work, and joined the rounds with staff. This made the clerkship a real apprenticeship. The student was no longer a passive listener in a hall. He was part of the patient care team, expected to learn through participation. The old bedside habits of questioning and listening returned in a stronger institutional form. What the laboratory did for the scientist, the clerkship did for the clinician. It tied knowledge to direct work. Even after the laboratory gained authority, the interview remained. The doctor still had to ask when the illness began, how it changed, what came before it, and what the patient could remember of it. Relatives and friends could help fill in what the patient could not supply. The point was not merely to collect facts, it was to arrange them in time and to test them against a living memory. A good history was not a loose conversation. It was a careful gathering of evidence from a person whose account had to be heard with patience. The human voice stayed central because disease still arrived in a life, not in isolation. The old habits of record keeping also remained. A case note had to be written soon after the visit, while the facts were still fresh. It had to present the leading symptoms in order, and sometimes note what was not there. It had to be clear enough for another physician to read later and understand what had been seen. That kind of writing gave medicine a public form. It allowed a case to be reviewed, discussed, and compared. The notebook on the desk, the chart on the wall, and the ledger in the clinic office all served the same purpose. They made the fleeting moment of a visit available to later scrutiny. Bedside teaching stayed alive because the work was still passed from one physician to another by example. Senior doctors did not merely explain, they showed. Students watched how the patient was approached, how questions were shaped, how the physical examination was carried out, and how the findings were recorded. Much of medical knowledge traveled that way for a long time, through habit and repetition, rather than through formal instruction alone. The room itself became a lesson. The ward, the bed, the chart, the exam table, and the post-mortem room all helped train the next generation. The craft survived because it was useful, repeatable, and grounded in the real movement of patients through care. What remained in modern medicine was a set of linked practices rather than a single triumph. The laboratory enlarged the questions, the hospital gathered the material, the university gave the work a place to grow, the record preserved the details, the interview kept the patient present, the physical examination continued to use the hand, the ear, and the eye. The autopsy still checked the story against the body. Modern medicine did not replace listening, it made listening part of a larger system of testing and teaching. The old discipline stayed inside the new one, carrying forward in a quieter, more exact form. That is why the history ends, not with a machine, but with a physician returning to the page after the round. The work still depends on looking closely, asking carefully, writing plainly, and comparing one account with the next until the shape of the illness comes into view. The tools changed. The rooms multiplied. The scale of knowledge widened. Yet the heart of the practice remained the same. One person attends to another, and what is heard in that small space is carried forward into the larger order of medicine. The same change can be seen in the places where medicine worked. Paris became a center because the city hospital gathered large numbers of sick people in one place, and the physician could follow disease through crowded wards, bedside notes, and post-mortem rooms. In that setting, Pierre-Louis made the clinical case into a disciplined sequence. He asked about previous health, occupation, family history, and habits. He traced the present illness in time. He set the patient's words beside his own examination. He kept a careful record as the illness unfolded. When death came, he sought the autopsy and wrote down what the body revealed. Then he compared one group with another, even testing whether bloodletting actually helped the patient. The result mattered because it showed that listening had to be joined to comparison, and comparison to restraint. An impression was no longer enough. The story of the disease had to be checked against evidence. That habit of checking the story spread as medicine moved north and east. Urban migration in Europe and the French hospital system had placed a concentration of illness before physicians that earlier generations never knew. In Germany, the university became the place where laboratory science, pathology, physiology, chemistry, and bacteriology could work on disease from another angle. The physician was no longer only a bedside observer, he was also a student of causes, mechanisms, and instruments. The thermometer, microscope, ophthalmoscope, kymograph, sphygmomanometer, and X-ray did not replace the senses. They extended them and made them more exact. The clinical ear still mattered, but it now lived beside a growing apparatus of measurement. In America, the old medical schools could not keep pace. Students often entered with little more than the ability to pay their fees, and many were trained by lecture alone. But the war, the hospitals, and the return of physicians trained in Europe exposed how thin that education had become. Reform came slowly, then all at once. Harvard, Pennsylvania, Michigan, and finally Johns Hopkins tied medicine to the university, to laboratories, and to the patient bedside. Science no longer belonged in one room and care in another. They were joined by a curriculum that expected the student to think, to investigate, and to work. Osler gave that union a human shape. At Johns Hopkins, he built a clinic with residents of graded experience, close bedside teaching, and students who did not merely watch but participated. They took histories, performed physical examinations, carried out laboratory work, and made rounds with the faculty. The clerkship made the ward a school, and the school a ward. It turned the patient into the center of instruction, without reducing the patient to a specimen. The modern physician learned to move back and forth among the chart, the microscope, the ward bed, and the autopsy table, carrying each form of knowledge into the next. So the new medicine did not silence the older arts, it disciplined them. It required better notes, better timing, better comparison, better institutions, and better habits of mind. The hospital gave the case volume, the laboratory gave it mechanism, the university gave it permanence, the bedside gave it meaning. Listening remained the first act, but now it was supported by records, instruments, teaching rounds, and a scientific culture that asked the physician to verify what the ear had heard. What remained, then, was not a relic, it was a method, it was the patient voice, carried into a system large enough to test it, refine it, and remember it. In that arrangement, even failure had use. A missed sign could be corrected in the record, a false certainty challenged by a later case, and a habit of care handed down from one resident to the next. The bedside remained the beginning, but it was no longer the end.